waiting for a few more people to come in, but we'll get started. And when they come, they come. So I think everyone here, I actually,
Hello, Yael.
you all know who I am. I'm Tracy. So,
Hi.
hello. And let's see, I want to welcome everyone to the 5th in our series tonight of Elder Law 101, Lessons for Life Planning. This is the last in the series. This program will be taped tonight, so please, I guess we'll mute the microphone, so please don't unmute until the end when we have questions and answers. And the last 15 minutes are for questions and answers. And then if you have questions at the end, you can type it to Audrey directly, or you can just write to everyone, and Audrey will pick up the questions and she will ask questions of Dawn. So Temple Emmanuel, as you know, offers an array of social programs for active older adults, free to the community, total body workout, Zumba Gold, Artful Afternoons, L'chaim concerts, as well as adult support group, caregiver support group, memory cafe, and more. If you want information, just send me a chat and I'll send you some information. I also just want to quickly acknowledge the Newton Senior Center for promoting this program. Before the speakers begin, I want to also acknowledge Benchmark. Benchmark is underwriting this series, and tonight we have Megan Romeo from Benchmark at Evans Park in Newton Corner, and she's been with us before, and she's just going to say hi and say hello and have a few words. Megan?
Hello, everyone. Thank you so much for joining us. I can't believe that it's the 5th and the final series of this event. It has been a true pleasure to be a part of this presentation, to get to know Dawn and Audrey, and to firsthand hear and be a part of their expertise and knowledge. It's been a true pleasure. I am with Evans Park, which is a Benchmark community in Newton, Mass. We offer independent living, as well as assisted living, memory care, as well as respite programs. We are also looking forward to restarting our day program in the coming months, hopefully by the summer, which would be fantastic. If anyone has any questions specifically about my community or about our 5 sister communities all within the Newton area, please don't hesitate to let Tracy know or to send me a private message in this group.
Great, thank you, Megan. Thank you as always. And now I want to introduce our speakers, Dawn Friedman and Audrey Zabin. And tonight's topic are frequently asked questions. What does Medicare cover? What are my options for care services? The rehab says my husband's Medicare coverage ends tomorrow, but he can't come home. Where do I start when there isn't time to plan? Dawn, Audrey, take it away. Thank you.
Okay.
Good evening, everyone. So glad to be here with you tonight. And we've got a lot of information to cover. I think you got the handouts that Don prepared ahead of time. And while I think the bulk of our conversation is going to speak about Medicaid or Mass Health, as it's called here in Massachusetts, we first wanted to review Medicare. What's the difference between Medicare and Medicaid? How is it used and not used? So, you know, Don and I were just talking about this subject, and I'm going to let Don talk about one of the most frequent times of the year when we get all the Medicare information. If you're over 65, you get a ton of mail about Medicare. So, Don, maybe you want to talk about the differences between all the different levels of Medicare.
All right, fine, good. I get many calls in the office about this. People get all this mail. It's not actually from Medicare, which is part of the Social Security Administration. It's from private companies, and they say they have a free alternative, and they throw in gym memberships and do dental care and all kinds of things. This is always in the fall because it's kicking off the open enrollment period, it's called, where you have some choices to make. So, but these choices have kind of grown topsy-turvy over the years, and many people feel kind of a little left behind. They're on the original Medicare that they always had, and they ask, well, what is this about? Is it scam? Is it real? What's it about? So when we say Medicare, we're really talking about a variety of programs. There is the original Medicare, which comes with a red, white, and blue card, ID card. And that's, we recognize that. There's Part A for hospital services and Part B for medical services. There's Part D we hear about is for prescription drug coverage. There actually is a Part C.
Yeah.
Doesn't really go by that nomenclature very much, but it's called Medicare Advantage programs. And this is an option that the government evolved and has really grown greatly in recent years. Medicare C, or Medicare Advantage, is a set of programs that where the government turns over funds to private insurance companies for people who enroll in the program. It's sort of, you think of it as a kind of a combination of Medicare Part A and B collapsed and given as a contract to a private insurance company, which then doles the services back. It's, people have, it's grown to the point where I was very surprised about this, that in Massachusetts, something like 40% of people who are of Medicare age are not on the original Medicare, which is actually what it's called. Original Medicare, you'll sometimes see it as traditional Medicare. That's the basic program. But 40% of people now are on one of these Medicare Advantage programs.
Or some of the other.
And there are a series of kind of add-on programs for special populations. There are a series of programs for people who are eligible for both Mass Health and Medicare. They're called duly eligible people. There's a program called PACE. There's a program called SCO. There are a variety of these special programs that, again, it's a package, and it's administered by a private agency, sometimes nonprofit, sometimes profit. They do a lot of marketing, and people, evaluate them. They have to meet certain federal requirements, but they have a lot of flexibility in what they do.
And they don't have a lot. They do and they don't.
Well, they do, well, right. I mean, as to what they can do, they have a lot of flexibility. As to once they decide what they're going to do, how much flexibility there is within that framework is very limited.
Right.
I think the biggest difference I see between Medicare Advantage and Medicare is that the Medicare Advantage programs are basically like HMOs. There's a limited constellation of people, of physicians and hospitals and nursing homes, skilled nursing facilities that participate. And you really have to take financial advantage of the situation. You have to go to one of the people in their network, one of the facilities in their network. If you don't, you may be covered to a much lesser extent, if at all. Apropos to this particular conversation on the topic tonight, if you are in a Medicare Advantage program, it's critical that you look at everything that I'm going to say, all of these questions, from the point of view of the material that your program gives you, because much of it is different.
Right.
I'll be talking about really largely the general requirements in original Medicare. There are a host of these other programs. There's just no way of trying to cover them in any way. But I think the critical thing is you pay close attention to it before you sign up, understand the limitations of it. There are some free add-ons, but they typically are things which sort of catch your eye, not necessarily things that really make up the difference.
Yeah,
Private insurance companies pay 20-25% of their revenue on advertising and marketing and administration. Medicare pays about 5% of its revenue on that. So it's, you have to wonder, you just have to be cautious and careful about what it is that you're buying into.
I never even thought about what percentage they paid for advertising, but I can tell you, as a social worker, as a geriatric social worker and care manager, I often advise clients when they're looking at this, as you age, you want more options for care and treaters and not less. So while these advantage programs may be very attractive because they may offer a gym membership, or they may offer a discount on glasses or whatever, I would urge you to look at the array of options for you for actual care. If you get a diagnosis, do you have to stay with the oncologist in that program? That may or may not be to your advantage. So like Don said, I urge you to look at all that's offered, because the other part of this is there are only certain times of the year that you can switch your insurance. Open enrollment is only at certain times of year. And certainly there are lots of ways that you can evaluate this. And I see in the chat, someone keeps referring to the SHINE program, which is a wonderful senior volunteer program that sits down with seniors to evaluate and review all your health insurance options before you make a decision. But I think a good rule of thumb here, Don, is as you age, you want more options.
Right.
You don't want to have limited options.
Exactly right. We find many times that younger at 65, the early end of Medicare, yes, will do fine on these programs, but partly it's because they don't need a lot. You know, the programs also, the way they're funded is that they're given a certain amount of money for each person who participates. So they're very conscious of how much they're spending on each person. Medicare looks at every person, but the budgeting doesn't work that way. It's if your services are justified for 30 days, you're going to get 30 days. Medicare isn't going to feel that it's spending too much on you. So it's just a different structure.
Right. So talk a bit about Medicare and what original Medicare usually covers.
All right, and let me focus maybe on the nursing home issue specifically. That was kind of our case.
Mm-hmm.
So we have a situation where a person is in the hospital, is coming on an emergency room admission, a suspicion of a heart attack. Not really sure what happened, but the EMTs felt he needed to be covered. So went to the hospital, and the person is there for several days, and the hospital decides that he's pretty good. There's some more things they think could need some skilled follow-up. They're a little concerned about his little imbalance in his walking, concerned about falls, feel he should get some PT. And so they recommend going to a skilled, it's called a skilled nursing facility, a SNF is the abbreviation. It's typically called a rehab. You know, it's a nursing home that does Medicare rehab services. And the question arises as to how this is going to get paid. And people have heard about a 3-day rule and other kinds of requirements for Medicare coverage of skilled nursing care. And there is something called a 3-day rule, and there are a couple of things to watch out for this. The first is the question of sort of what counts toward the 3 days. Your being in the hospital does not necessarily count. There are 2 ways that you're carried on the books of the hospital. One is as an outpatient, even if you're sleeping there. The other is as an inpatient, where you're actually admitted to the hospital. The outpatient status is sometimes called observation status. When you go to the emergency room, you are not admitted to the hospital. You're there in this sort of outpatient.
So just to be clear, if you go to the emergency room and you stay overnight, you are not technically admitted.
Right. You may or may not. I mean, it's unusual to be admitted the first night. Now, and so you have no immediate control over that issue, but you do need to know it. Someone needs to know it if they're concerned about the possibility of, or the desirability of Medicare paying for any rehab placement that might follow on the hospital placement, which is very common. So you have to find out that you're actually there on admission status. Then you start counting, and they count in an odd kind of way. The first part of the day, even if it's a minute that you're on admission status, counts as a full day. But the last day that you're in the hospital, even if you're there for 23 and a half hours, does not count.
Right.
So it's going to work to your advantage or not, but it basically means you have to be on admission status for 3 nights. is really what it amounts to. And you'll find that out as you go and talk to them as you're at the hospital if you ask the question. So that's the first piece of it. Now there is
just to repeat that, Don, because we had a question about it. Repeat the idea, tell us again about how exactly you qualify as Medicare for rehab
all right.
in the hospital.
Okay. Well, all right. So there's a sort of a clinical aspect of that.
Right.
Right. They have to decide that you need either skilled nursing care. This is by a doctor's decision, not your feeling about it, that you need skilled nursing care or skilled therapy services, which is physical therapy, occupational therapy, or speech therapy. But this is from it's a skilled therapist, not just therapy services in general. And that this is going to be provided under a written care plan of care, and it's a kind of a service that can be provided only in a skilled facility.
Right.
It can't be provided at home.
Right. And sometimes, Don, I believe that part of the evaluation also includes, are you able to go home and will you be safe at home? Versus getting a visiting nurse to come in versus going to a real facility.
Right.
Well, that's a clinical factor as well.
It is, but still they have to find that there's some skilled response.
You have to have a skilled need.
It may be that your need is for assistance with personal care. You're not safe getting in and out of a shower.
Right.
That's not a skilled care,
right.
And that doesn't justify. If you qualify as needing skilled care and you also need personal care of that kind, you can get personal care, but the personal care won't come on its own. Medicare.
So typically, my experience has been, if you need ongoing skilled nursing or some kind of ongoing supervision, then you'll be admitted to a nursing home rather than going home. Right. And we're just talking about how someone leaves the hospital. What determines whether they go home or to a rehab?
Good. Okay. Good point. All right. So on the skilled care, you still need skilled care, but if it's only intermittent, then it's a home care recommendation.
That's right.
Under Medicare. There is one important exception to the 3-day rule, which is it doesn't really appear much in the literature, but it's, at least in the Boston area, it's becoming very, very prominent. Medicare has made arrangements with physicians and hospitals and skilled nursing facilities, where if they organize themselves as a kind of a special care group, then Medicare will agree that patients who are in that care group, that physician or that group of physicians in that hospital, can be placed directly to a skilled nursing facility without meeting the 3-day requirement. It's a new program. It started on a pilot basis about 4 years ago. It happened to be, it involved my mother. I was one of the first people actually got involved in this, and we were sort of experimenting with it a little bit. But the idea was that they were trying to avoid a situation where people were staying longer than they needed to at the hospital because there was such pressure on the system to sort of keep them in Medicare coverage, such pressure on the physicians to do it. And they felt that if they could move people earlier and still hold out the carrot of Medicare coverage at the nursing home, the whole thing would be better. The patient would be better off in getting out of the hospital where they're exposed to all kinds of potential complications of just being there. And the Medicare system would help because the Medicare would be paying at a skilled nursing rate rather than a hospital rate.
What's the name of that program again?
It's 3 initials that I'll remember by the time we close. But
okay.
Okay. It's I'm sorry, I don't have it in front.
That's okay.
I've got it. So that's kind of the thing on the 3-day rule and home care versus There's another point of often confusion having to do with the 100-day rule. Should we go to
Right.
that? The next.
Right.
These are these kind of benchmark notions within the Medicare system. Medicare covers skilled nursing, and these other skilled services in a skilled nursing facility. If you meet that entry qualification, but not for an unlimited period of time. And also, it does not cover personal care in isolation. I mean, if the only thing you need is personal care, then you don't have to, then Medicare won't cover it.
Right.
But if you're in the nursing home, getting personal care and skilled care, there's a time limit of 100 days per, and then there's I'm doing air quotes if you can say, per spell of illness.
Right.
This is a Medicare concept. It's not 100 days lifetime. It's 100 days
per incident.
Sort of incident and period of hospitalization and nursing home days. The way it works is that, the easiest case is that if you're at the facility and you stay there and you continue to need nursing care, go through your 100 days, and then the Medicare coverage will stop. And you'll have to switch either to private pay or to long-term care under Mass Health. That's a topic we'll get to in a few minutes, sort of how to make that switch. The more frequent case is one where somebody is in the rehab for 2 weeks or 3 weeks. They're kind of back on their feet. They've regained their balance capacity. They've sharpened up their ability to manage at home. They may still need just intermittent care at home, a VNA coming in once a week or twice a week, maybe a physical therapy appointment every couple of days, but it's sort of at that level of intermittent. So after the 2 weeks, they go home. Now, if a week later or 2.5 weeks later, things begin to deteriorate again and they need to be re-hospitalized, they can go back to the hospital without having a new 3-day event. If it's within the 30 days, you just go back to the hospital, go back home, but you can go back and forth. And the 30 days, the 100 days continues to accumulate within that period.
The clock keeps
use up the 100
ticking.
days
Yeah.
over the course of 6 months.
Right.
If there's short periods of back and forth. If you're out of the hospital, out of the nursing home for more than 30 days, however, then you can get back to the hospital and kick off another 100 days.
Right.
Depending on a lot of small things, but that's the basic idea. So it's kind of 100 days per time of having a spell of illness and a particular problem. But if the problems get more complicated, if new ones intercede, you may be re-hospitalized in new periods of time.
So it's actually done by per diagnosis. So whatever the original diagnosis is, if you you have a repeat diagnosis for the same diagnosis, that's how it continues.
Right.
I'm saying incident, but it's really diagnosis.
Right. Or illness,
So,
in their spell of illness,
right.
That's what they're talking about.
So before we go to Mass Health, let's just be clear now on what Medicare, we're just talking Medicare now, will pay for. So we know it pays for short-term rehab in a skilled nursing facility. It pays for VNA, which is Visiting Nurse Association, which is where you can have a skilled nurse coming to visit you at home. Also, there are other licensed therapists who will come and visit you at home. And Medicare will also pay for you going, while you're living at home, going out to a rehab for other, like physical therapy. So
Yes.
Those are the 3 things that Medicare will cover. What everyone needs to understand, and I think Don and I both get this question a lot, is, well, my aunt had X number of days of Medicare coverage, and now my mother won't get it. Okay. So this is a very individualized assessment of each patient, what goes into this formula, this assessment, is the diagnosis and your ability to improve with the therapy that's being provided. Okay, so I always get a call on a Friday afternoon. My mother's being kicked off of Medicare, and she has to go to, she has to come home right away. And what do? Well, there is an appeal process that you can do. Don, do you want to talk about what that Medicare appeal process is like in a rehab?
Well, yes, I mean, there is an appeal process, and it's quick. It's operated by private contractors, these quality care organizations, and it is possible to do it there, by phone, by quick contact and so forth. My experience is that it's very difficult to get them to reverse in any significant way. And unless you really have your medical ducks lined up to oppose the position that the facility is taking, it really is probably worth your while to focus on other alternatives.
Putting your energy into getting them home safely.
Yeah.
And that's been my experience.
You might win. It might take you 4 days to win. They'll give you 3 extra days. You'll still be 1 day behind, and you won't be closer. You know, the key thing is that while there's a 100-day limit, hardly anybody exhausts that in a single stay. You know, the more typical thing, even for people who really need a lot of follow-on help, is a couple of weeks.
What about COVID, Don?
All right. COVID is, I'd actually copied out a bunch of things that ended up not being really appropriate to try to include in the packet. But if you do it yourselves, you can do it. Just do COVID Medicare and you come up with a bunch of things. It turns out that there's a great deal of flexibility that's been added into all of these programs now to deal specifically with COVID situations of people who can't, should be off Medicare in the nursing home, but can't go home because of the unsafe condition at home. They're making all kinds of allowances for additional Medicare days and coverage. Mass Health is doing the same thing. They're not terminating people from the program. They're doing all kinds of things to try to deal with this crisis. It's a very quickly moving target. They're not even an issue they're not modifying regulations on this. They're doing it by policy. So the best thing to do is to raise the question specifically, if you're dealing with a COVID situation, ask, how are you dealing with this in light of COVID? How can you send my mother home? Oh, maybe she's medically ready, but there are 7 people living in that house and 5 kids, and she can't go home. So realistically, what do we do? It's been kind of too fast to follow to try to generalize what's going on.
So the next thing we wanted to cover with Medicare was the homebound requirement for Medicare Home.
Right. All right. So Medicare, when you're at home, Medicare can provide services in a couple of different ways. One is just on an outpatient basis, where you go to PT, or PT comes to your house. Another way where it's more intensive in-the-house care, involving regular visits by a visiting nurse, and typically more than a few days of PT or OT or speech, and often home health aid services to deal with personal care issues, never on a 24/7 basis, but some significant time, and for a period of time. This might be 30 days. Typically, you kind of do it in 30-day bunches, but often less than that. That's the Medicare home care program. Medicaid also provides similar services at home for people who aren't in that high level of medical need. This might involve some VNA visits, but much less often. It may involve some PT or OT. Typically involves more personal care attendant services, just a different balance. It's more on the maintenance of people at home safely rather than the medical treatment focus of Medicare.
Less skilled.
Yeah, there's also, just to mention the full array, the state also has a home care program, which is also partially funded by Medicaid and partially just by state budget. It's called the State Home Care Program. It's run through the network of state aging service access point programs.
Area agencies on aging.
Yeah, there are 39 or so of them scattered around the state. You can access the list of them through the Executive Office of Elder Affairs. It's really administered by that office as a state agency. They provide, by and large, they're a kind of a clearinghouse for services and information and referral. They also administer a significant part of the Medicaid program, the Mass Health program. They provide personal care attendance. They also provide services relating to household, what's it called? Just house maintenance kinds of things.
Home adaptation and that kind of
thing. And transportation and sort of non-medical services as an adjunct. So very often people are working with some different array of these three sets of services over time at home, and really want to try to exhaust what you can of each of them.
Do you want to say something about the Frail Elder Waiver Program before we go into Mass Health?
I think it's a good bridging program. All right.
Yeah.
So we're going to talk now about the Mass Health array of programs. And this is also hard to talk about in this context. I tried to cover a good amount of it in the handout that I did. And there's some references in the references sheet I had, which has the links to different things. I found a good overview of the Massachusetts Medicaid program in a piece developed for the National Council on Aging. It's on, I think it's useful to look for as an overview. But for this program, we want to focus. Medicaid has been a focus of different aspects of Medicaid over the course of the five programs. This one we really want to focus on the situation.
The application.
Person who is, let's stay with our same case, person who is in the nursing home, has exhausted Medicare coverage, but isn't ready to come home.
Or can't.
Can
no longer live at home.
They can't live at home, can't medically or care-wise, there's nobody else there.
Right.
They can't live alone. But they're at a point where they don't need a lot of regular skilled care. They don't need to see a nurse every week. So the program that picks up at that point is one of two. It's, it could be long-term care insurance as a private adjunct. It can be just private payment, or it's Medicaid or Mass Health. Same thing. Mass Health is just our name for Medicaid.
And sometimes you might hear facilities call it a Medicare bed versus a long-term care bed.
Yeah.
Because they are often in different parts of the nursing home too, which sometimes confuses people, but they are often separated.
Yeah, well, they're really not. Yeah, they are, and part of it they say is because the services required of Medicare patients is different than that for Medicaid patients. Right. My experience though with most nursing homes is that they very seldom can work out the situation where they're actually on different floors or different places. It really depends on how many people they have in each group. If they have an empty bed in the Medicare wing and they have somebody to fill it, they're going to fill it.
Yeah.
In any event, it's really the spots they have available in the facility.
The open beds.
The bed that doesn't say Medicare on it and is only for Medicare.
No.
In fact, the Medicaid law is very clear that nursing homes really can't provide different services for people who are paying privately or on Medicaid.
But it is confusing sometimes, I think, for families when they're used to their mom or dad being there and having physical therapy twice a week because Medicare is paying for that. And then they shift to a long-term bed and suddenly the therapy's gone.
Well, it doesn't need to be gone. I mean, the physical therapy is a little unusual in that it can be provided both under the skilled nursing facility, which is really part of the hospital services. It's really part of that Medicare A. But you can get physical therapy also under Medicare B, which is more the physician, outpatient, non-hospital setting, non-SNF setting. And it is possible, you still have to make the same clinical case, but it is possible for it to be provided there, and also to a limited extent under Mass Health itself. You just have to make the case that it's a medical need.
Sometimes you have to advocate for that.
Right. Right. So there's one. So Medicare, the Mass Health eligibility is very complicated. It's very different for couples and for individuals. It's very different if you're in the community, meaning at home or assisted living or some setting like that, or if you're in, or in a nursing home. When they talk about community Medicaid, they're also including hospital. So it's really,
Right.
it's
That's
complicated.
right.
So, but I want to highlight, we'll both be highlighting a couple of special programs that I think don't get enough press. One of them is called the Frail Elder Waiver Program. This is a program for elders who are at home. It could be an individual or it could be a married couple, one of whom is really in kind of serious health problematical shape and one is relatively well. When we're talking about the couples, we usually refer to them as the well spouse and the ill spouse, just to distinguish them. But this is a situation where Medicaid makes a very huge change in the financial eligibility criteria for people who are getting Medicaid at home. Without this, the usual rule, if it's just two elders at home, to get on Medicaid as a couple, their assets can't exceed $3,000 and their income has to be very, very, very low. And certainly there are people who qualify for that, but it's fortunately, it's not that many people. They decided that they had the idea of this waiver program is that, well, look, sometimes we have people at home who are so sick and so debilitated that they really could be in a nursing home. If they qualify for nursing home placement, they go to the nursing home on Medicaid, it's going to cost the state a fortune. If, on the other hand, if we lighten up on these financial eligibility rules and encourage them to stay at home and allow them to stay at home and provide them services at home without having to impoverish themselves, then this would really be a huge advantage for them, as well as a matter of public policy. We want to states always trying to keep people at home getting care rather than in an institution. The expense and also just the humanity of the situation is so much more what people want. So with the Frail Elder Program, they said that, look, if you would qualify for a nursing home, we're going to apply the same rules for Medicaid that we would if you were talking about a nursing home. And these are much more favorable. And we'll let you stay at home. Now, the nursing home rules for a couple, just to draw the contrast, so instead of $3,000 for the couple, the rule is that the spouse who's sick is limited to only $2,000. But the spouse who is well can have up to, right now the number is $130,380. That's the community spouse asset allowance.
Mm-hmm.
In addition, the couple can keep their house, they can keep a car, and there are actually, we'll talk about some of the strategies. There are also things that they can do to actually protect even a substantially higher level of assets than that. So while it doesn't open community home-based Medicaid coverage for everyone, or even for the majority of people, it does really for a very, very large number of people who are in middle income, middle asset situations.
Right. And it allows some semblance of care while you're still maintaining your life in the community. And for well spouses, it allows them the opportunity to still stay together while the ill senior is being cared for. And inevitably, there's one who's sick and one who's the caregiver. So it
Okay.
does allow them to be together,
Right. Right.
which is a nice thing. You know, we don't have a lot of mass health programs that will allow that. So.
Right. Now, before I go, I want to go into the ways of trying to deal with this system to make the most of it, the exceptions to the asset counting and all of that. Let me just step back a step to one of the forks in the road we just went to was to go from the nursing home on Medicare to home, possibly on the frail elder waiver program.
Mhm.
That road could have forked in the other direction with saying that, well, person doesn't have a spouse at home to take care of him, or the spouse is herself too frail to take care of him. He's going to have to stay in the nursing home on long-term care. So let's talk about that briefly, the financial pieces of that.
Mhm.
It's really the same as a frail elder. Let's make it the husband just for sake of ease of pronoun.
Yeah.
The husband is in the nursing home. His assets can't exceed more than $2,000, can't exceed 2,000. But the spouse at home can have this 130,000 plus the house plus other things that we'll get to. So the question often comes up as to, well, sort of what counts toward that 130,000 and what doesn't count.
Mhm.
And then is there anything that we can do to sort of to move closer to that in a way which doesn't cause a problem?
Mhm.
When I say cause a problem, everybody knows about hears about the look back rule.
The spend down.
The rule that Medicaid has that if they feel that you're impoverishing yourself to bring yourself down by giving your money away to bring yourself down to a level of where you would qualify for Medicaid, that's a no-no. There's a penalty period involved in that. Penalty period can actually be longer than 5 years. You don't want to do these transfers or gifts or putting money, just trying to put money
Trust
aside.
creating, right.
Yeah, if it's going to be trust, you got to be very careful with that. We'll talk a little bit about kinds of trusts that work and those that don't. But that's the problem. So I'm not quite eligible now, or I don't know whether I'm eligible. I'm looking at my assets, what counts, what doesn't. So let's do the what counts, what doesn't first, and then we'll talk about ways beyond that. So the one main thing that doesn't count is the value of the house. Now, this is they're really thinking about the equity value of the house. That is the fair market value minus the mortgages that are outstanding on the house. That's called the fair market net value. That's the number they're looking at. Now, there is a number in the regulations. It's a pretty high number. It's $980,000 or something like that this year. But even that number isn't a limitation if there's a spouse living at home, or if you may or want to keep open the possibility of your returning home. But they disregard the value of the house in most instances. Now, a car, personal effects, personal belongings, those are sort of simple things and low cost things that don't count. There are a couple of other things that get passed over. One has to do with some joint financial accounts. Now, this is mentioned it's in the list in the material. It often gets overlooked.
What do you mean by looked over, Don?
Yeah, I meant overlooked as a possibility. All right, so picture the situation. You've got two accounts.
Mm-hmm.
It's a husband and wife and one of your kids.
Yeah.
And the kid has been on there for years. And one of those accounts is a bank account.
Mm-hmm. And
one is an investment account. It's not an IRA that can't have joint names on it, but it's $100,000 in a brokerage account, and that has 3 names on it.
Yeah.
If that account, this rule applies to non-bank accounts.
Okay.
So this is just the brokerage accounts, things other than can't be CDs or bank accounts, not things in a bank. Why this rule exists this way is anybody's guess, but they did it this way, not thinking about it, I think, and they never bothered to change it. But if it's a non-bank account, you actually have a right to allocate the funds based on the number of people, and the joint owners can withdraw funds from the account in proportion to their ownership
Ownership.
without it being considered as a transfer. So you could reduce this account by a third by having your son withdraw a third of the account. It's not a transfer and it's permissible. Now, what he does with the account is, sort of between you and him. Your hope is that he'll understand that you're doing this to try to protect assets for yourself, for your own care, if you're going to need it. Assets do belong to him, but at least it gives you a way of trying to protect. If it's only two owners, it's half of the asset. So it can be a significant amount.
Huh.
Bank accounts are counted differently. Bank accounts are just assumed to belong to the person who's applying for Medicaid. The only way to get around that is to show that the other person contributed to that account. But that typically isn't the case. With a mother-daughter account, the daughter is usually on there for convenience. She's not putting her money into her mother's account.
There's money.
Yeah. There's another approach that we've gotten good mileage in. It's a little more subtle and difficult, but it involves people who may have a second home, whether in Massachusetts or not. There is an
You mean whether the homes are in Massachusetts?
Yeah, their residence is Massachusetts, but they might have a place
like in Florida or something.
Or Florida, right? Now, ordinarily, real estate that is not part of your personal residence is just a countable asset. They look at the fair market value of that and they charge it toward that $130,000 cap. But there's an exception that applies to, it's called property that is essential for self-support. That's the exception. And if this property is income producing, within limits, if it's income producing, it doesn't have to be making a lot of money, but it has to be making enough for you to make the case that this is a helpful part of your living budget. Then you can make the case that this is property which is essential for self-support and therefore not countable for mass health purposes. And often, in fact, even if we're planning sort of well in advance, this is something that we talk to clients about doing or being prepared to do. There are also some real tax advantages to doing this, and you can avoid having to sell the place. Sometimes there are capital gains problems with the sale of these second houses and so forth.
Yeah.
There may be lots of reasons to think about doing this, but this is one. Now, this is one that you can't take advantage of at the last minute because you have to, be in a rental situation. But it's something that if you're planning it all in advance, you can do. It, like the joint ownership rule, that also is not one that you can fully implement at the last minute unless the account has been there for 5 years. The look back rule factors into this.
So tell us again what the look back period, how long is that? It's worth repeating.
All right, it's shorthand is it's 5 years from the time that you're applying for Medicaid. It gets more complicated than that because your date of eligibility may be different from date of application, but that's the way to think about it.
Mm-hmm.
That you shouldn't apply until 5 years has passed from the date of your last disqualifying transfer that isn't one of the exceptions that we'll talk about in a minute. That's another topic. There are certain, one common misconception is that there is some magic number, some amount of money. It's typically thought of as $15,000 that people feel is an amount that they understand is allowed, that I can give $15,000 per year to my kids without it coming within this look back. This is a confusion with a federal gift tax rule that relates to $15,000. Has nothing to do with Medicaid.
Has nothing to do with mass health.
People have asked that question. Well, can't I give 15?
No.
And the answer is no.
No.
There's no minimum amount in the regulations. It just says anything transferred, and they could hypothetically apply that to very small amounts of money. In practice, our experience is that they really don't ask for information on transfers of less than $1,000. But that's really just a kind of a rule of thumb, could vary with different workers. What it really means is that you really, if you're in a situation where you are getting concerned about having limited assets, getting concerned about illness, concerned about long-term care, particularly if you don't have long-term care insurance, this is a time when you have to become very, very careful about, not doing something that's going to, even if you run out of assets later, is going to bar your eligibility. This is a key reason why we really advise people if we're just doing estate planning with people and they're turning 60 or 62 or 65, even if they're not planning on any Medicaid planning at that point, we want to at least alert them to the dangers of doing something that might interfere with their future eligibility.
But the topic for tonight really was sort of a more urgent nature.
Let's get into the urgent. Okay.
And so, is there anything we can do after we've run out of time to plan?
Yeah. Well, the first thing has to do with that ownership issue. I mean, if you are renting a place, these are things you should talk to a lawyer about before making your case to Medicaid, these exceptions, but they're there and they're there to be explored. If you're renting a place now, there's at least this possibility of protecting it through this mechanism. If you have joint non-bank assets, this is something that should factor in. These are things that can be done at the last minute if the arrangements have been in place for a while. Following that, the way the state views it with the joint ownership thing is that if you've set that up, you've sort of made a gift of 1/3 of an interest in that account to your son 5 years ago when his name got added to it. So if you take it out now, after 5 years, it's not a problem. So that's something you can do at the last minute in certain circumstances. So let's talk about other things that can be done that don't cause a transfer problem. One thing is that you can transfer things to the spouse. As I mentioned, that the ill spouse the spouse in the nursing home can't have more than 2,000, and he's got more than that. So you can transfer money over to the well spouse without it causing a transfer problem.
Don't forget the person who doesn't have a spouse.
Right. All right. So, the person who doesn't have a spouse can't transfer it to a spouse. Right. All right. So you can transfer money to a disabled or blind child of, either spouse. Only one if you only have one. If you're old. But you can transfer money to a disabled or blind child without a transfer penalty. This is an
adult child.
Adult child. Well, actually, also you can transfer a house to somebody under 21, even if they're not disabled. That's a separate point here about the house specifically. But there are certain, now these exceptions are largely built on the idea of, there being some, interest, public interest in the protection of other people in the family, beyond just, having them inherit your money. There's no particular public interest in that, at least if you're not a Republican. So in that context, there are several people who are identified. One are very young children or children under 21, even though technically adults. You can transfer, if you own a residence, you can transfer it to them without a penalty. You can, with a child who is disabled, you can transfer either to that individual. Let's say the child is physically disabled, but and on Social Security, but able to manage funds. You can, or to a trust for that individual, or to a pool trust. There are a couple of different kinds of trust arrangements that you can transfer money to without it being considered a penalty.
And excuse me, Don, just make sure everybody understands they can attach the house.
Well, right.
Explain that to people.
Not if they transfer it. I mean, if they transfer the house,
but
if they're owning the house and just relying on the fact that it doesn't count as an asset, the state can put a lien on the property. It doesn't prevent its sale, but what it does is that it alerts the buyer to the fact that the house is being sold, and if the house is sold, the state has to be involved in that. I mean, they basically have to find out about it. They can't prevent it. It's called notice lien. They can't make a claim directly. But at that point, they can say that, well, now we know that you have, all these assets and you're not eligible for Medicaid anymore. If the lien is still on there when the person dies, then at that point, the state can come back and make a claim for reimbursement against the house.
Okay.
So the
Okay.
fact that the house is protected in letting you get on Medicaid isn't a complete protection.
Right.
On the other hand, there are things, and this, especially if you have spouses, there's so much more you can do if it's a married couple. For instance, if it's a spouse, husband's in the nursing home, husband owns the house, say.
Mhm.
Husband transfers ownership to the wife. Husband is the only one on Medicaid. State can't put a lien on the house because the wife
She's
is
living there.
she's living there and she's not,
I'm using Medicaid.
she's not
right.
using Medicaid, so the
Right.
lien doesn't apply to her. She then, in fact, once he's on Medicaid, she can sell the house, even though that will raise her assets way above the $130,000 level. I mean, she may decide that she really doesn't need the house anymore. She'd rather move in with her daughter, someplace else.
Well, what if she has to sell the house and move to an assisted living?
That's all right. So she may need to sell the house to raise money for her own care.
Her own care.
Medicaid issue that solves a couple. Well, first of all, from a Medicaid point of view, it doesn't disqualify her husband. He can stay on Medicaid. She's not going to have to
Right.
start paying privately.
Okay.
The resources to pay privately in assisted living, which Medicaid doesn't cover by and large.
Mhm.
So it's, it doesn't matter of timing. If she had sold the house a week before Medicaid was approved,
Yes.
then she's out of luck. Then instead of having 130,000, she's got 530,000.
Okay, so now we just decided you really need to consult an elder law attorney.
Yeah. It's sort
Okay.
of what and what to do. There are a couple of other things to mention about these special exceptions. One has to do with another exception that's sort of sounds a little bizarre, but it's an exception that if a transfer is made exclusively for a purpose other than to qualify for Medicaid, it's not disqualifying.
Okay.
The public policy here is that they don't want people making transfers to make themselves eligible. The
Right.
law acknowledges that there may be reasons for people to make a transfer that are good, appropriate, valid reasons. They may have an impact on their potential Medicaid eligibility, but if they're not for that purpose, one would be that, for instance, if the couple spent, let's say they had a disabled child that needed an operation, and neither of them the parents are not in a nursing home or anything. This is happening long in advance of that, and they lay out $300,000 for the child's medical care. And at the same time, they sold their house. They still have 200,000 of their own assets, and they're fine. They're not going into a nursing home. No, the state, and then the husband has a stroke. And
Okay.
all of a sudden, the situation is reversed.
Right.
They're looking at the look back period. They see this $300,000 transfer benefiting somebody else in the look back period. That's not going to be a disqualifying.
It's not a disqualifier.
That's an easy one. There's another one we were just looking at today, where there was a $5,000 payment. We were reviewing the client's preparation of the Medicaid application. We're going through their records for 5 years to see what they had forgotten about transfers. And they had spent $5,000 on a granddaughter's wedding.
Okay.
4 years and 10 months before. And they're for Medicaid now.
Oh, wow.
So
Okay.
we talked about that in the office and decided that was also, at the time, there was only $5,000.
It was only 5,000.
It had
right?
no impact on grandma's, potential for Medicaid eligibility as a practical matter. She was still 4 years away from going into a nursing home. It wasn't anything imminent. It wasn't that she was deciding to do that instead of spending it on the nursing home.
Her
So-
granddaughter didn't decide to get married so her grandmother could
No.
qualify for Medicaid.
No, that would have been really tricky. But so that it is one that I think can be used if there's really a compelling case for it.
Mhm.
Highly suspect by the state. The state, they don't trust anything. They don't. For instance, paying for care is obviously okay. I mean, that's you're paying for your care. For
Right,
yourself.
if you hire private home health aides.
Yeah, if
Mhm.
you hire your kid, it becomes another
Great
question.
example, right?
Their attitude is that kids, by and large, take care of their parents out of love and affection. They don't do it as a job, and they're not doing it with the expectation of of getting paid. On the other hand, if somebody's daughter had a job and is providing live-in care for her mother at home, had to give up the job, for the mother to agree to
Yes.
pay the daughter either some kind of going rate for her time or for what she's losing from her job,
Income, yes.
it's you can make a plausible case for it. The thing about it is that you have to make the case in advance. You have when the situation arises that you're providing care and there's concern about long-term care in the future, that's the time to talk to somebody about actually having a formal agreement that you can then later show the state.
The
that this
state
is a
will ask you for that
contract,
kind of thing?
just as with an Audrey Zabin. I hired my daughter instead of Audrey.
But the state will ask for that kind of a document or
They ask for
verification?
verification of it, and then specifically they ask for written agreements in advance, not something that was concocted
Okay.
after the fact. The problem is that we've had so many people who've come in and it said, we'll ask, well, you took out $50,000 from your mother's account, last week. We want to apply for Medicaid now. What was that about? Well, my mother owed that to us for all that we've done, and she owed us that, and yada yada, which could very well have been true in the sense that they had laid out this amount of money, but the state won't allow anything like that. If the kids are going to be, and this we often run into a situation where the children might loan money to the parent.
Mm-hmm.
Provide for their care, maybe until the house is going to be sold. They don't know when it's
Right.
going to happen, but they're
Right.
loaning money in the hope that they can get repaid at some point. And then, but mom still has excess assets, and they say, well, mom, give us the money back now so you can go on to Medicaid in the nursing home. The state's going to look for a written loan agreement. They're not going to take your word that this was a loan. You expect repayment, you expect terms, you expect requirements, some degree of formality. So this is something you really have to do in advance. If you plan in advance, you can do a lot at the last minute. It's a hard way to answer this question.
Oh, that's
For instance,
okay.
if you're going into a situation where you're making loans to the parent, providing, rather than making a gift to the parent, can be the same money you're giving each month. But if you do it as a loan, there's a possibility of repayment and avoiding having to spend down that last $50,000. If you do it as a gift, there's no chance. If the parent decides to pay you back later, it's not an obligation. They can pay off debts, they can pay mortgages down, but they can't just pay back things that they're now considering debts.
So really planning for last minute is sort of what we're saying here.
Well, even the joint account business, if we're talking to people at 65, long before this is a concern, we'll say that, well, think about adding one of your kids to your Fidelity account.
Mm-hmm.
Why?
Mm-hmm.
It may give you this option in the future.
Mm-hmm. Mm-hmm.
Think about renting the place on the Cape, part-time, so you can show it over
Some
time. You've got
income.
a producing property and not something you just pull together at the end. You can do renovations on your house, and if you're thinking of doing that, doing it, in advance. That you can't do quickly. Legally, you can, they don't care when you're spending the money on renovations that you need for health and safety.
Yes.
But that's something you really have to, because it takes a while to execute. But if you think about it in advance, do the bathroom rehab, so you've got a walk-in shower, or whatever you're going to do to make things accessible. Do it a little in advance, and not at the last minute when it's too late.
Before we end today, we have a few more minutes. One thing I'd love to talk about is special needs trusts.
Yeah.
People ask me about that all the time, and I wonder if you could give us some clarity on that.
Okay. First, on terminology, the terminology is very unfortunate. I mean, for decades, we wrote things, we called special needs trusts. Special needs became big with the special ed law back in 1972, and was children with special needs. It was a new way, it's kind of a nicer way of talking about people with with severe disabilities or impairments. So we called special needs trusts, which might be trusts that parents would write in their estate plan. They were leaving a portion of their assets to each of their kids, leaving a portion for their child who's on the spectrum or mentally ill or intellectually disabled, was left in trust, partly because the child couldn't manage it, partly because the parents didn't want to have a situation where they left money, made the child ineligible for benefits, and it required the money to have to be spent down. We did the fourth program was actually on this topic, and there's a tape and materials that Tracy can give you on that. But so in this context now of transfers, there was a special kind of a special needs trust authorized since 1996 by under federal law that allows two things. It allows a disabled individual himself to put his own money into trust for himself. For instance, an accident settlement or a settlement from an accident recovery or an inheritance that wasn't planned.
Is there a dollar limit for that?
There's an age limit of 65 for that. There is also, this also for the child has a limit, but not for the parent. If a parent has a child who is disabled on Social Security or SSI, and the child is under age 65, the parent can transfer assets, any amount, to a special needs trust for that child without causing a disqualification. Whereas if they transferred the same money to their other kids, they'd be out of a nursing home for 5 years. There's another called a pooled trust. There's another device also in last week's program, we talked about that some, where a parent can put money into trust for herself and with some protection. There's a Medicaid claim against it at the end, but at least it allows the parent to set aside some funds for herself in a nursing home, just so she's not completely impoverished.
Destitute. Yeah.
That has been available for people of all ages and still is. The state's been talking about imposing an age limit of 65 on those trusts as well, but it hasn't implemented that yet.
Okay. Annuities?
Annuities. This is another the last minute topic. Boy, I'm glad you mentioned that. I guess I didn't put this on the page. This is a major strategy. It's mentioned in the article. We think of annuities, and I really, as a financial planning tool, I really don't have a great affection for them. It's not that my profession to say that, but they're expensive and they're cumbersome and they're inflexible. And you really, if you're being asked about an annuity in the context of elder planning or Medicaid stuff, be careful with it. There is one type of annuity, it's called an immediate annuity, that can be useful. Immediate annuity is basically a contract arrangement, financial arrangement, where you pay over a certain sum of money. This could be the excess assets that you have, the 100,000 that's over the 130, to an insurance company or an annuity company. And in consideration of that, they agree to pay you a certain amount each month for a period of time. And you can do the math. I mean, you can do it, if it's 5 years, if you want a 5-year annuity, they'll tell you what they'll pay back every 5 months, for over that period of time. You can do the math. You can set it up so that if you die in less than 5 months, the balance can go to somebody else. You can, or to your kids. And you can do the math and see that, well, you're not really going to make much money on this, if anything, but it still may be worth doing. The reason for that is that what it does is takes this 100,000 now that's interfering with eligibility. If you have 230,000 as the community spouse,
instead of 130, yeah.
If you take that 100,000 and make it into this annuity, it changes that. You don't have the 100,000 anymore. You've turned that over to somebody else for value. It's not a gift to anybody. In exchange for that, you're getting this flow of income, monthly income, that's coming back to you as a community spouse. And one of the beautiful aspects of the Medicaid financial rules is that the income of the community spouse is completely unrestricted. it has no effect on the Medicaid eligibility of the other spouse. So she can continue working, she can go back to work, she can do whatever she wants to do. She can, and she can have an annuity that's giving her $1,000 a month of income.
Yeah.
So it's an important tool. There's no waiting period with that. The annuity has to meet certain requirements. Don't
It's
do it.
something that can happen pretty quickly.
You have to know somebody who's been this route, and somebody who's dealing with an annuity company that's been this route, so they give you the proper paperwork on it. But it's something that's very effective and very done. You see, sometimes you see ads, in the, well, not so much in Massachusetts, but radio shows and things talk about sort of magic routes, or they take you out to dinner and they tell you about magic ways to get on Medicaid at the last minute. I think these largely are annuity arrangements, and I think that people often, I think, are too aggressive with these. Let me explain. This annuity exception wasn't just a matter of the state saying, well, let's really be nice, or it wasn't just a hole that they left in the system. It was part of a whole slew of law changes back in 1988 that had to do with situation of trying to avoid the impoverishment of the community spouse. That's the sort of the caption on this whole section of the law. It's the thing that said that the house was protected. The 130,000 was then 60,000, but it was that amount was part
not
of
impoverishing
the fact that none of the income of the community spouse has to be applied to the other spouse. There's even another rule that says that if the community spouse income is very low, she may be able to get some of the income of her ill spouse in the nursing home. Called this. There's a monthly needs allowance provision that can allow shifting of income from the ill spouse to the well spouse. These are all things that had to do with avoiding impoverishment. Now, the annuity, the way the annuity, the concern comes into that is if the annuity is set up and is providing a level of income that's reasonable in terms of the community spouse's needs. If it's an extra, if she's losing $2,000 of her husband's Social Security, and has needs at home still, most of her housing needs don't change for the fact
costs,
that then it's not at all implausible to think that, well, getting an extra 1,000 is going to help her out. That's really necessary. If you there's nothing in the regulations that limits the size of an annuity you can use. And some people have taken the position that, well, all right, I've got $2 million extra, and I'll just buy an annuity with $2 million. And so the community spouse is going to be getting income back of $100,000 a month. And the rules say that income to her doesn't matter.
Doesn't matter.
Yeah. But, this is one of those situations where it's a no waiting to happen. It's the test case waiting to happen. It's the last thing you want to,
it's your last resort for planning.
Is going to go to court and say, this has nothing to do with avoiding spousal impoverishment. It's an abuse of the system. There have been like cases, for instance, personal effects. So, household stuff. So you can buy things. You can buy a new refrigerator, and they're not going to consider that a disqualifying transfer. You can buy a new car. If your car is old and you need transportation, a car is okay. But if you buy a Lamborghini or a Ferrari, it's a different thing, and the state's going to view it differently.
Sure. Well, I don't think our listeners are buying Lamborghinis at the moment, but I want to leave them a few minutes.
Things don't buy rings to use. It's a matter of common sense and balance,
right?
And not trying to take undue advantage of these exceptions. That's
right. We have a few minutes, and I think Tracy said we can go a couple more minutes over. The time went by very quickly. Thank you, Don. Please write your questions in the chat. We do have a question about charitable gift annuities.
Yeah.
What are your thoughts on that? Are you favorable towards those?
Well, I think, I'm really not a financial planner. I mean, I look at these things primarily from the point of view of, impact on elder law healthcare issues. That's really my focus.
Yeah.
I'm not an investment specialist. I think that charitable gift annuities, are one issue with them that's different from the kind of annuity I'm talking about is that with the charitable gift annuity, you're getting a tax advantage from it when you set it up, and you're going to get something back depending on how long you live, but the payments don't continue for anyone else. They're life annuities. So they're good for people who need an income tax advantage and don't have any family needs beyond themselves. And they might be good for part of an estate, but they're really limited that way. They're primarily vehicles for making donations with some income tax advantage. You get an income tax deduction for it. If you gave $10,000 directly to the charity, you'd get a $10,000 deduction. If you give $10,000 to them on condition that they're going to pay you back a certain amount each month for the rest of your life, then you might get a $4,000 deduction because you're getting something back in value. So you're still getting a deduction. You're getting this secured flow of income, but it's not, it's not really it's not a useful tool in the context that we're talking about, where we're trying to protect either a community spouse or retain some assets for the family.
Any other questions? Tracy, do you have any questions in your,
Oh, I'm sorry, somebody asked me.
you're on mute.
There was a question, it was addressed just for a second, so I just want to make sure the person gets her answer. When you were talking mainly about couples, but the person did ask, if you don't have a spouse, or your spouse deceased, or you're divorced, or you were never married,
Yeah.
The elder who had no one at home to take care of them at home now, and now, about the elder who's at home and no one's taking care of them. So,
all right. Well, most of what I said is really applicable to both. Okay. That 130,000 business is the one thing that's different. The things about what are countable in terms of the joint accounts and all of that applies. Whether it's still, the fact is that if the law is really geared to protecting these vulnerable people, the community spouse and the disabled children, sometimes a sibling who is living in the house with the elder and has an interest in the house. That's another person who's potentially protected. But the law just isn't really interested in protecting the assets of people who don't have a spouse to protect, these vulnerable dependents. That's really what they're thinking about, the vulnerable dependents. It's not that they have it out for people who aren't married, but it's only these special policy reasons that created the need to create these special rules for the spouse.
Thank you.
One last question.
We have one that just came in.
Yeah, the other thing we can do on these, if we could, depending on who the question is for, Audrey, if you can, Tracy, if you can, we have any way of reaching these people back again? If people, do we have the, Tracy, do you have the email addresses for people who are sending questions?
I think we have addressed all the questions that were on the chat.
Okay, well, there's one, Cindy just sent in a long one at 7:34.
Oh, she might have sent it directly to you. Oh, she just sent it.
Just to everyone.
Okay. Yes.
All right. I can just copy
Can you
that.
see it? Okay.
I see it. I can just copy it and keep it. I guess the chat won't stay there.
Cindy, if you could put your because I don't know who Cindy is. Cindy, if you could just email me, and then I will and then we'll send that out to Dawn.
Yeah, actually, just in case I lose it at this end, if you could just copy your message, post that into the email, then I'll respond to it.
Okay.
If anybody else has any, if I've caused some confusion or something, I would look at the paper, and I think the Medicaid played a part of each of the 5 programs, and so I know that there was no way to cover it comprehensively, again tonight. So feel a little bad about that. I don't know what to do about it.
We covered a lot.
Yeah, but I was going to say was that if people look back at the topics, if there are other topics that they weren't here for and want to take, I guess the there are links available for recordings of all
For
five.
the
of them,
recordings that we
As
did.
well
yeah.
as well as the handout materials.
Well, if anyone has a question, email me because my email is on all the flyers. Email me directly and I will send it to Dawn or I'll send it to Audrey. If you wanted, somebody just emailed me, they wanted to reach out to Megan, I will connect you. So I'll do that after this is over. It's easier probably for them to email me because again, my email's on every flyer that they get. So it's
Yeah, okay. Yeah, do that.
right.
But again, am I right, Tracy, if people want the link for the recordings as well as the handout materials, you
I
can
have the
email that all
link
to
for
them.
all
We
the
can,
recordings. I do not have the link so far for the last one.
okay, but you will.
Every other recording I have sent out. But yes, if people did not get the links to the first 3 recordings, send me an email. I will send that out. I will find out if we have the video recording of the last one. If you have, if you missed one of the programs and you want any of the attachments that Dawn and Audrey sent, just email me. People usually have told me along the way that they missed, they were missing a program and they wanted the video, and I have sent that out to the people that have contacted me. Send me whatever questions you have, I'll forward it out. We just have to wrap it up. This program is the last and the 5th one in our elder law series. If you would like to, like I said, to contact Dawn or Audrey or Megan from Benchmark, send me an email. I'll forward everybody's contact information. Thank you, Megan, for all the work that you've done from Benchmark for sponsoring. And thank you to Dawn Friedman and Audrey Zabin for your knowledge and your professionalism. It's really been an honor and a pleasure to work with both of you. You both are just class acts. And I so appreciate that you've given your time and energy to this 5-part series. I want everyone to know that we started working on this in the summer, talking about it, trying to hone in what we were going to talk about. And Dawn and Audrey put countless hours of their free time into this 5-part series. And I just want to publicly acknowledge how wonderful it's been to work with both.
Well, Tracy, thank you for organizing and sticking with
Thank
it.
you.
And thank you, Sean, back in the back room.
Yes.
Sean is the tech who is managed this whole thing and kept
Oh,
us.
my pleasure. It was a
Couldn't
great
do it
session.
without you.
You're the best, Sean.
Well, that's not true.
Well, almost the best. Best I know.
All right, good night, everybody.
Good night,
Take care,
everyone.
Have a great evening.
Thank you all for being here.
Thank you, Megan. Thank you for
All
joining us.
right, bye, everybody.
Bye, everybody.
Good night.
Great.